My name is Giovanni Joel González Ochoa. My topic is ketoacidosis diabetic pediatric. Definition. It is acute the complication of diabetic that is produced by an absolute or relative deficit of insulin and an excess of counter-regulator hormones that together generate hyperglycemia and lead to a state of dehydration, accompanied by an electrolyte imbalance.
Potentially life-threatening complication of diabetes mellitus. DKA is commonly associated with type 1, but type 2 diabetics are also susceptible. DKA is caused by a critically low insulin level and is usually triggered when diabetic patients undergo further stress, such as infections, inadequate insulin administration, or cardiovascular diseases. It may also occur as the first presentation of diabetes in people who did not know they had diabetes and therefore did not have insulin treatment. Glucose is the major energy source of the body. It comes from digestion of carbohydrates and is carried by the bloodstream to various organs. Insulin is a hormone produced by beta cells of the pancreas and is responsible for driving glucose into cells. When insulin is deficient, glucose cannot enter the cells. It stays in the blood, causing high blood sugar levels while the cells are starved. In response to this metabolic starvation, the body increases the levels of counter-regulatory hormones. These hormones have two major effects that are responsible for clinical presentation of DKA. First, they produce more glucose in an attempt to supply energy to the cells. This is done by breaking down glycogen into glucose and synthesizing glucose from non-carbohydrate substrates, such as proteins and lipids. However, as the cells cannot use glucose, this response only results in more sugar in the blood. As blood sugar level exceeds the ability of the kidneys to reabsorb, it overflows into urine, taking water and electrolytes along with it in a process known as osmotic diuresis. This results in large volumes of urine, dehydration, and excessive thirst. Second, they activate lipolysis and fatty acid metabolism for alternative fuel. In the liver, metabolism of fatty acids as an alternative energy source produces ketone bodies. One of these is acetone, a volatile substance that gives DKA patients breath, a characteristic sweet smell. Ketone bodies, unlike fatty acids, can cross the blood-brain barrier and therefore can serve as fuel for the brain during glucose starvation. They are, however, acidic, and when produced in large amounts, overwhelm the buffering capacity of blood plasma, resulting in metabolic acidosis. As the body tries to reduce blood acidity by exhaling more carbon dioxide, a deep and laboured breathing, known as Kussmaul breathing, may result. Another compensation mechanism for high acidity moves hydrogen ions into cells in exchange for potassium. This leads to increased potassium levels in the blood. But as potassium is constantly excreted into urine during osmotic diuresis, the overall potassium level in the body is eventually depleted. A blood test may indicate too much potassium or hyperkalemia, but once insulin treatment starts, potassium moves back into cells and hypokalemia may result instead. For this reason, blood potassium level is monitored throughout treatment, and potassium replacement is usually required together with intravenous fluid and insulin as primary treatment for DKA.
Thank you for watching. Please feel free to suggest a topic you want us to cover by leaving a comment below.
Application in nursing. Number 1. Administration of food therapy and medication. Number 2. The eyes, the water balance, and monitor hydration, skin color, urine, etc. Number 3. Control of vital signs and blood glucose. Number 4. Look for possible signs of infection. Number 5. Monitor change in cognitive status. Number 6. Foster a climate of trust with the patient and with the family members.
Brain injury is an uncommon but important complication of pediatric diabetic ketoacidosis. One hypothesis has been that rapid infusion of intravenous fluids during treatment causes a reduction in serum osmolality, leading to brain edema and injury. Current recommendations based on retrospective studies suggest using a slow infusion of isotonic fluids. In a multicenter randomized clinical trial with a 2x2 factorial design, investigators evaluated 1,389 episodes of diabetic ketoacidosis in 1,255 children from 13 urban emergency departments in the United States. The children were assigned to either a rapid or a slow infusion strategy, and all received an initial bolus of 10 milliliters of 0.9% sodium chloride solution per kilogram. The rapid infusion group received an additional bolus of 10 milliliters of 0.9% sodium chloride solution per kilogram, and a fluid deficit of 10% of body weight was assumed, of which half was replaced over the initial 12 hours and half over the next 24 hours. The slow infusion group did not receive an additional bolus, and a fluid deficit of 5% of body weight was assumed, and was replaced evenly over 48 hours. Within each infusion group, children were assigned to either 0.45% or 0.9% sodium chloride solution for replacement after the initial fluid boluses. All other treatments for diabetic ketoacidosis were identical. The primary outcome was a decline in mental status, as defined by a Glasgow Coma Scale score of less than 14. Scores were obtained hourly for 24 hours or until the resolution of diabetic ketoacidosis. There was no significant difference in the rate of the primary outcome between the rapid and slow infusion groups, or between the 0.45% and 0.9% saline groups. Serious adverse events were rare and occurred with similar frequency in all groups. The authors conclude that neither the rate of administration nor the sodium content of intravenous fluids significantly influences neurologic outcomes in children with diabetic ketoacidosis. Full trial results are available at nejm.org.
Pros and cons. Pros. Number 1. The positive side is that the nursing staff is involved with the patient and can understand all the needs they have and thus be able to help them. Number 2. After prompt attention from medical personnel, cerebral edema can be prevented, which is the main sign. Number 3. After a timely diagnosis, it is possible to prevent these diseases and thus reduce the incidence. Cons. Number 1. Children under the age of 5 are at increased risk for diabetic ketoacidosis. Number 2. Diabetic ketoacidosis and its comorbidities generate a very high cost in the service of care. Number 3. Cerebral edema represents 5% with a mortality of 19%.
Diabetes is a growing problem both in the United States and worldwide. At this time, there are over 1.25 million Americans with type 1 diabetes, of which nearly 190,000 are children. The incidence of diabetes is increasing 3% annually worldwide. From 2001 to 2009, there has been a 23% increase in the number of children diagnosed each year with type 1 diabetes.
Conclusion. Pediatric ketoacidosis is a metabolic disorder with a high rate of cases that can have high morbidity and mortality if it is not treated at time. So that pathophysiological mechanism has been established to prevent this disease. Thank you.